Welcome everyone. Today we are going to talk about post-traumatic stress disorder. This is an anxiety disorder which is caused by very stressful, frightening and distressing events. DSM-4-TR, that is a text revision, describes the setting event for PTSD as exposure to a traumatic event during which someone feels the fear, helplessness or horror. After that, the victim re-experiences this event through memories and nightmares. When memories occur suddenly and the victims find themselves reliving the event, it is said that they are having a flashback. They avoid anything which reminds them about the trauma. They display a characteristic restriction or numbing of emotional responsiveness, which may become disruptive to interpersonal relationships. They are sometimes unable to remember certain aspects of the event too, probably an unconscious attempt to avoid the experience of emotion itself. In all, they are chronically over-aroused, easily startled and quick in their anger. PTSD typically develops after a terrifying ordeal that involved physical harm or the threat of physical harm. The person who develops PTSD may have been the one who was harmed, himself or herself. The harm may have happened to a loved one, or the person may have witnessed a harmful event that happened to loved ones or even strangers. What are the various events which can cause PTSD? There are a variety of events which may cause PTSD, like serious road accidents, violent personal assaults such as sexual assault, mugging or robbery, or prolonged sexual abuse, violence or severe neglect for that matter, witnessing violent deaths or military combat, or being held hostage, or terrorist attacks, or for that matter even natural disasters such as severe floods, earthquakes or tsunamis. Any of these may be the events which may be responsible for PTSD in certain individuals. PTSD can develop immediately after someone experiences a disturbing event, or it can occur months, weeks or even years later. PTSD is estimated to affect about 1 in every 3 people who have had a traumatic experience, but it is not exactly clear why some people develop the condition and others don't. Let us look at the various symptoms associated with PTSD. PTSD is characterized by intense fear, helplessness or horror, or disorganized or agitated behavior if it is children, and resulting from the exposure to this severe or extreme trauma that they have experienced. The characteristic symptoms include persistent re-experiencing of the traumatic event, persistent avoidance of stimuli associated with the trauma, and numbing of general responsiveness, and persistent symptoms of increased autonomic arousal. The full symptom picture must be present for at least more than 1 month, and the disturbance must cause clinically significant distress or impairment in social, occupational or other important areas of functioning, so that only then it can be categorized as PTSD. There are certain categories of symptoms which are prominently discussed according to DSM-4-TR. Let us first look at these categories of these symptoms and then go into the details of the symptoms. The symptoms that I have been mentioning about can be grouped broadly into 3 categories. One is re-experiencing symptoms, second is avoidance symptoms, and the third is hyperarousal symptoms. Let us look at each of these symptoms individually. First, we will talk about re-experiencing symptoms. These involve what are called flashbacks, that is, reliving of trauma over and over, including physical symptoms like a racing heart or sweating. They tend to get bad dreams, they have frightening thoughts. The re-experiencing symptoms may cause problems in the routine, the everyday routine of the individual. They can start from the person's own thoughts and feelings and words, objects or situations which are reminders of the event can also trigger this re-experiencing that we have been talking about. In addition to re-experiencing symptoms, we also said there are what are called avoidance symptoms. What are avoidance symptoms? Staying away from places, events or objects which are reminders of the experience that they have had, the traumatic experience that they have had, feeling emotionally numb, feeling strong guilt, depression or worry, losing interest in activities which have been enjoyable in the past, having trouble remembering the dangerous event. Things that remind a person of the traumatic event can themselves trigger avoidance symptoms. And these symptoms may cause this individual to change his or her personal routine. For example, after a train accident, a person who is regularly traveling by train all these days would stop traveling, may avoid traveling by train. Then the third category of symptoms that we need to discuss are hyperarousal symptoms. Hyperarousal refers to being easily startled, feeling tensed or on edge, having difficulty sleeping and or having angry outbursts. Hyperarousal symptoms are usually constant instead of being triggered by any thoughts or things that remind one of the traumatic event that they have experienced. They can make the person feel stressed and angry, and these symptoms may make it hard for the individual to do his daily tasks such as sleeping, eating or concentrating. While these are commonly seen in adults, there are certain symptoms which are seen in children in particular. Children and teens, for that matter, can have extreme reactions to trauma, but their symptoms may not be the same as adults. In very young children, for example, the symptoms may include bedwetting, when they had learned how to use the toilet actually before the traumatic event. They may be forgetting how to talk, or there may be an inability to talk. Acting out the scary event during their playtime may be done. Being unusually clingy with the parent or other significant adults may be seen. Older children and teens may usually show symptoms more like those which we have discussed with reference to adults. They may also develop disruptive, disrespectful or destructive behaviors as well. And older children and teens may feel guilty for not preventing the injury or deaths. They may also have thoughts of revenge. In order to diagnose the problem as PTSD, there are certain criteria which have been prescribed by DSM-4-TR. We will look into those criteria. Before that, let us basically discuss about how the person is diagnosed with PTSD. Not every traumatized person develops full-blown or even minor PTSD. We have to remember this fact. Symptoms usually begin within 3 months of the accident, but occasionally emerge years afterward too. They must last more than a month to be considered as PTSD. And the course of illness may vary with individuals. Some people recover within 6 months, while others have symptoms which may last longer. In some people, the condition becomes chronic. Symptoms that make it hard to go about daily life, going to school or work, being with friends and taking care of important tasks, all these become hard. To be diagnosed with PTSD, a person must have at least 1 or more of re-experiencing symptoms, and at least 3 or more of avoidance symptoms, and at least 2 or more of hyperarousal symptoms for more than 1 month. It is diagnosed as acute PTSD 1 month after the PTSD occurs, and when it continues longer than 3 months, then it is considered as chronic PTSD. And this chronic PTSD is usually associated with more prominent avoidance behavior, as well as with more frequent co-occurrence of additional diagnoses like social phobia. PTSD is often accompanied by depression, substance abuse, or 1 or more of other anxiety disorders which have been enlisted in DSM-4-TR. Now let us look at the criteria which I have been mentioning with reference to DSM-4-TR criteria. American Psychiatric Association in 2000 in its Diagnostic and Statistical Manual of Mental Disorders, namely DSM-4 TR for text revision, specified certain criteria. They include a history. The diagnostic criteria for PTSD include a history of exposure to a traumatic event meeting 2 criteria and symptoms from each of the 3 symptom clusters which we have mentioned and also which we are going to talk about now. And these symptom clusters are intrusive recollections, avoidant or numbing symptoms, and hyperarousal symptoms. 5th criterion concerns duration of symptoms, and a 6th assesses the functioning. So let us go by these criteria one by one. Let's first talk about the criterion A, which is the stressor. DSM-4 TR criterion A says that the person has been exposed to a traumatic event in which both of what I am going to tell now have been present. The first of them being the person has experienced, witnessed or have been confronted with an event or events that involve actual or threatened death or serious injury, or a threat to the physical integrity of oneself or the others. And the second is the person's response involved intense fear, helplessness or horror. What we have to note over here is, according to DSM-4 TR, in children it may be expressed instead by disorganized or agitated behavior. Criterion B talks about intrusive recollection, which means the traumatic event is persistently re-experienced in at least one of the ways that I am going to talk about now. The first, recurrent and intrusive distressing recollections of the event, including images, thoughts or perceptions. Recurrent distressing dreams of the event. And the third is acting or feeling as if the traumatic event were recurring, which includes a sense of reliving the experience, illusions, hallucinations and dissociative flashback episodes, including those that occur upon awakening or when intoxicated. The fourth is an intense psychological distress at exposure to internal or external cues that symbolize or resemble an aspect of the traumatic event. Criterion C talks about the avoidant or numbing behavior, which is a persistent avoidance of stimuli associated with the trauma and numbing of general responsiveness which is not present before the trauma. And this is indicated by at least 3 of the symptoms which I am going to talk about now. The first is efforts to avoid thoughts, feelings or conversations associated with the trauma. Efforts to avoid activities, places or people that arouse recollections of the trauma. Inability to recall an important aspect of the trauma. Markedly diminished interest or participation in significant activities. Feeling of detachment or estrangement from others and a restricted range of affect. That is, for example, being unable to have any feelings at all. And finally, a sense of foreshortened future. For example, the person does not expect to have a career, marriage, children or a normal lifespan as well. Now, there is another criterion, that is the criterion D, which indicates hyperarousal, which refers to persistent symptoms of increasing arousal which was not present before the traumatic event. And this is indicated by at least 2 of the features which I am going to talk about now. The first, difficulty falling or staying asleep. Second is irritability or outbursts of anger. Third is difficulty concentrating. Fourth is hypervigilance. And fifth is exaggerated startle response. Criterion E refers to the duration, that is the duration of the disturbance of symptoms in criterion B, C and D we have discussed so far, that is for more than 1 month. Criterion F talks about functional significance, that is the disturbance causes clinically significant distress or impairment in the individual with respect to social, occupational or other important areas of functioning. In addition, DSM-4 TR says that it is to be specified if the disorder is acute, that is if duration of symptoms is less than 3 months, or whether it is chronic, that is if duration of symptoms is 3 months or more. Also to be specified if with or without delay onset, that is onset of symptoms at least 6 months after the stressor. Let us now discuss the causes of PTSD. Many scientists currently are focusing on genes which play a role in creating fear memories. Understanding how fear memories are created may help to refine or find new interventions with relation to reducing the symptoms of PTSD. Studying parts of brain involved in dealing with fear and stress also helps researchers to better understand possible causes of PTSD. One such brain structure is amygdala, known for its role in emotion, learning and memory, as you are all aware of. The amygdala appears to be active in fear acquisition or learning to fear an event, as well as in the early stages of fear extinction or learning not to fear. Brain structures and brain chemicals have both been implicated as the causes of PTSD. Research shows that exposure to trauma can cause what is called fear conditioning of the brain. Fear conditioning is where the person or the individual learns to predict traumas, and the predicted trauma can cause parts of the brain to be activated. With post-traumatic stress disorder that we are discussing currently, fear conditioning causes the brain to anticipate danger where none exists, where no situation actually exists, and thus causing PTSD conditions. Along with the biological vulnerability, which researchers talk extensively about, psychological vulnerability of the individual has been discussed too. Social and cultural factors also seem to play a very significant role. Let me talk about certain research findings in this context. What do researchers have to say about the causes of PTSD? Researchers say that there is a strong correlation between the level of danger perceived by the individual exposed to the trauma and the likelihood of developing PTSD. Other predictive factors include previous exposure to trauma and a personal and family history of psychiatric disorders, particularly depressive disorder. Some persons seem to have more likely than others to develop PTSD. This is because of their genetic composition. Genetic factors can influence the risk of exposure, according to studies, to some forms of trauma, probably through individual differences in personality which influence the environmental factors. It is difficult to know to what extent the increased vulnerability to PTSD in family members of trauma survivors is related to the biological and genetic phenomena as opposed to the experiential ones, because of the large degree of shared environment in the families. This brings us to the discussion of two components, that is the risk factors and resilience factors. What are risk factors and resilience factors? In fact, many factors play a part in whether a person gets PTSD or doesn't get it. Some of these are called risk factors, which make a person more likely to get PTSD. Other factors, which are called resilience factors that I have just mentioned, can help reduce the risk of the disorder. So, some of these risk and resilience factors are present before the trauma, and others become important during and after a traumatic event. Let us first look at some of these risk factors. One of the major risk factors which we have to look at is living through dangerous events and traumas. The second is having a history of mental illness, getting hurt deeply severely, seeing people get hurt or killed, feeling the horror, helplessness or extreme fear, having little or no social support after the event, dealing with extra stress after the event such as loss of a loved one, pain and injury, or loss of a job or home. On the other hand, there are these resilience factors which are helpful, like for example, seeking out support from other people like friends and family, finding a support group after the traumatic event, feeling good about one's own actions in the face of danger, having a coping strategy or a way of getting through the bad event and learning from it, being able to act and respond effectively despite feeling the fear. Researchers are studying the importance of various risk factors as well as resilience factors which may contribute toward identifying strengths and vulnerabilities to prevent the onset of PTSD. So far we have discussed about the symptoms, we have discussed about the causes, we have discussed about risk factors and resilience factors. Let us now look at the therapeutic aspects of PTSD. PTSD can be successfully treated even when it develops after many years of a traumatic event. Any treatment depends upon the severity of symptoms and how soon they occur after the traumatic event. The treatment options usually recommended are both psychological and pharmacological. Psychological treatment such as trauma-focused cognitive behavioral therapy, which is called CBT, or eye movement desensitization and reprocessing, which is called EMDR, and many other techniques which we are going to shortly discuss. In addition to this, antidepressant medication is also recommended. What do studies have to say about psychological therapeutic techniques? Studies say that psychological intervention after trauma appears to be meeting some real and symbolic needs of the victim, helping them overcome their sense of helplessness and guilt about surviving as well as other overwhelming emotions. It is also pointed that immediacy has been thought to enhance the efficacy of the psychological intervention in accordance with the notion that the earlier the intervention takes place, the less the opportunity for maladaptive and disruptive cognitive and behavioral patterns to become established. Psychotherapy involves thus talking on the basis of the needs at the level of one-to-one or in group. It usually lasts 6 to 12 weeks, but it may take more time as well. Research shows that support from family and friends can be an important part of the therapy. Many types of psychotherapy can help people with PTSD. Some types target the symptoms of PTSD directly. Other therapies focus on social, family or job related problems which may be because of PTSD. The therapist may combine different therapies and techniques depending upon the needs of the individual who is suffering. So let us now have a further look into these therapies. We will start off with psychodynamic therapies. Psychodynamic therapy helps to explore and understand the unconscious aspects of the trauma and its personal meaning to that particular individual. This form of treatment may be necessary for multiple traumatic events which are experienced over time. For example, childhood abuse in a dysfunctional family. You are seeing that one adds to the other. It's got a cumulative effect upon the individual. Another way of looking at the therapeutic techniques is the behavior modification techniques. These behavior modification techniques involve changing the maladaptive behavior patterns into more adaptive and healthy behavioral patterns. Various therapies have been enlisted, especially with relation to cognitive behavioral therapy. We all know cognitive behavioral therapy is also called CBT. It's supposed to be very helpful in dealing with PTSD. It's a way of helping to think differently about memories so that they become less distressing and more manageable. It will usually also involve some relaxation work to help the individual tolerate the discomfort of thinking about the traumatic events. It encompasses many approaches like systematic desensitization, relaxation training, biofeedback, cognitive processing therapy, stress inoculation training, assertiveness training, exposure therapy, combined stress inoculation training, combined exposure therapy, relaxation training with cognitive therapy as well. Let us look at least some of these techniques. Cognitive restructuring, for example, helps people make sense of the bad memories that they have been going through. Sometimes people remember the event differently than how it happened. They may feel guilt or shame about what is not their fault. The therapist helps people with PTSD look at what happened in a more realistic way. Stress inoculation training is another technique which tries to reduce PTSD symptoms by teaching a person how to reduce his anxiety. Like cognitive restructuring, this stress inoculation training helps people look at their memories in a more healthy way. Relaxation, which we have been discussing with reference to many other problems too, it's a feeling of calm in body and mind. It is used along with other therapies which may be helpful in stressful situations to reduce the tension and increase the control which one feels over self and the situations. Exposure therapy is one more much talked about therapy which helps people face and control their fear and fears. It exposes them to the trauma that they have experienced in a safer way. Remember, we said re-experiencing of the trauma is fearful, is anxiety provoking, creates tension, whereas here is a therapy which exposes them to the trauma that they have experienced in a much safer way. It uses mental imagery, writing or visits to the place where the event has happened. The therapist uses these tools to help people with PTSD cope with their several feelings that we have been talking about. Psychodrama is another technique which employs guided dramatic action to examine problems or issues which are raised by an individual. Psychodrama facilitates insight in an individual, personal growth in an individual, and an integration of cognitive, affective, and behavioral levels. It clarifies issues, it increases physical and emotional well-being, enhances learning and developing new skills as well. Then let us also talk about another technique which is called EMDR, that is eye movement desensitization and reprocessing. This is a technique which uses eye movements to help the brain to process flashbacks and to make sense of the traumatic experience. Other therapies involve family therapy and group therapies, among others. What is family therapy? It is a form of psychotherapy. We have discussed about it at length in some of our earlier sessions. It's a form of psychotherapy which treats the family rather than the individual, bringing the entire family together for therapeutic sessions. Group therapy, on the other hand, involves meeting with a group of other people who underwent the same experience or a similar traumatic event. The fact that other people in the group do have some idea of what one has been going through in itself can make it much easier for the person to talk about what has actually happened to him.